Good morning, everybody. My name is Kelly McAleer, and I am with the Kenney group, but also was recently asked to become the incoming healthcare chair for the Salt Lake Chamber. So it's a pleasure to be here today. And as Utah and our nation are facing another surge of the coronavirus 19 cases and our ICU beds are near full capacity, the headlines continue to send us mixed messages, and it is increasingly difficult for us to cipher between facts and fiction. It is critical that our community get accurate information and guidance that will help our community and the world get on top of this global pandemic that we are all so tired of, especially our healthcare workers today. We are pleased to have joining the Salt Lake Chamber and having you with us today this morning to hear from our local healthcare experts that are working on the front line. Today, we will hear the facts straight from the people that have the real expertise and help us get over the finish line here. I would like to introduce this morning's speakers. Dr. Graves, from Associate Professor with the Division of General Internal Medicine at the Internal Medicine at the University of Utah Health. Dr. Jarrett, Chief Medical Officer of Steward Health. Dr. Roos, Chief Medical Officer of MountainStar Health. Dr. Stenhjem, Infectious Disease at Intermountain Health. I'd like to turn it over to you guys, but before I do, I just wanted to give you guys a huge thank you from our community. Thank you so much for everything you're doing on the front lines to help us battle this. And we cannot thank you enough, and you are our true heroes, so thank you. What I'd like to do is just turn it over just briefly for you guys to introduce and just give us a little context of what you're actually your role is in your job, and then I will ask you a series of questions, and then hopefully if we have time left over, then we can have some of our audience ask questions. So why don't I start with Dr. Graves.
Good morning. Thank you for having me. You all can hear me, okay? I'm going to assume yes. Thank you, Dr. Stenhjem. I am an associate professor of general internal medicine. I am a hospital medicine provider as well as a palliative medicine provider. So I see very sick people admitted to the hospital. I also am associate chief medical officer at the university and have been working on the COVID-19 pandemic since March of 2020. So largely what I do is work on our capacity, our staffing, things like that for the University of Utah.
Thank you. Dr. Jarrett. I guess he hasn't joined us yet. How about Dr. Roos?
Good morning. Thank you, Kelly, for having us on your show, and appreciate it. So my name is Filip Roos. I am the Division Chief Medical Officer for MountainStar Healthcare, and I am responsible for a provision of clinical care across Utah, Idaho, and Alaska. In the past, I was actually a cardiac anesthesiologist and echocardiographer, and that was my previous job. And I took care of a lot of people in the intensive care unit as well. So again, thank you for having us.
Thank you. Dr. Stenhjem.
Yeah, thanks. Thanks for allowing us to be here. I'm the Senior Medical Director of Medical Specialties for Intermountain Healthcare, so I oversee 9 medical specialties for the enterprise. I'm also an infectious disease physician. I care for patients in the hospital at Intermountain Medical Center, and have been one of the ID COVID leads for Intermountain Healthcare. And then also lead a number of our vaccine effectiveness studies for the organization as well.
Great, thank you so much. Let me just start with, I'm going to go now backwards, and I'll just start with Dr. Stenhjem and ask this question, then we'll have a conversation around it. But COVID-19 cases are still high in Utah. What is the status of the hospital capacity at Intermountain?
Yeah, so I just pulled up our capacity board right here to be able to share just real time with you. So as of about 5 minutes ago, when this was updated, our COVID ICU hub capacity, so that's the big COVID centers, so Intermountain Medical Center, McKay, Utah Valley, St. George, we're at 98.15% occupancy. And so we're completely full. There, when I look at the different hospitals, there's a number of hospitals that are definitely over capacity and some that are just a couple beds under capacity. So we're essentially at 100% capacity. When we look at all ICU beds across the organization, so not just COVID hubs, but all ICU beds, we're at 97% capacity. So we're full, totally full. And, you know, as the others on this call will know, it's really hard to operate a hospital with ICUs that are at 98% capacity. There's just no buffer there to bring people in, get them out. And so it is a huge challenge. And keep in mind, this is after we've discontinued surgeries that need ICU beds post-surgery. So this is even after we've put in some really significant interventions that are really hard on patients. You know, we sometimes think of these as elective surgeries. These are not elective surgeries for patients that require, you know, bypass surgeries or, you know, major vascular surgeries. And so to answer your question, Kelly, is we're totally full.
How about Dr. Roos, MountainStar Health?
So we're in an identical situation. I mean, overall, our ICU occupancy across the state is then 89% right now. It will be very different, you know, 5 minutes from now, but we've been oscillating around probably high 80s to mid 90s. In the big hospitals, we're the flag hospital, St. Mark's, for instance, right now we're at 100% occupancy. And earlier this week, we were over 100% in other hospitals where we had to actually house ICU level patients outside of the ICU. So overall, it's very similar to identical situation to Intermountain.
And Dr. Graves, how about the University of Utah?
The university is in a similar situation to HCA as well as Intermountain. So our ICU for COVID patients is over 100% full, meaning that we have COVID patients in other ICUs. We have accommodated those rooms to be able to safely do that with airflow, but that is outside of what we have allocated for COVID. In addition to that, our entire ICU capacity is 96% full. So we are also full. I agree with Intermountain in that it becomes very, very difficult to have patients flow through your hospital when there are no available ICU beds. And so we are in the same situation.
Troubling. Dr. Jarrett, welcome to the panel. This is Dr. Jarrett, and he's the Chief Medical Officer of Steward Health. So welcome to the panel. And we were just getting up to date. Why don't you just tell us a little bit about your role at Steward Health, and then and get us updated on the hospital capacity there.
Thanks, Kelly. I apologize for being late. Had some urgent business I was tied up with, but nice to be with you. I'm the Arlen Jarrett. I'm the Chief Medical Officer for the Steward, Utah region of 5 hospitals. I'm an OBGYN by training, but I've been in this role for about 10 years. I work with all the people on the screen here. We see each other frequently throughout the week. We're in multiple meetings with the state and with each other, constantly in communication with each other. From what I heard from Dr. Stenhjem, Dr. Graves, and Dr. Roos, Steward is in the same boat. We're all struggling at this time with the amount of patients that we have coming through our doors. We have been at 100% in our ICUs and near full in our non-ICU beds. But on a given day, if we just can't fill one nursing position, we don't have we can't even fill up all the rooms that we have available, because one nurse sometimes will put us out of commission for a few beds, and that's been very tough. We're doing all of the mitigation efforts that others are doing, looking at and postponing and canceling, as we say, elective surgeries, but they're again, I agree that that's a very relative term, because they're not always elective to the person who's needing it. we are our biggest struggle probably through right now is just through staffing. I mean, we have equipment, we have beds, we have ventilators, we have medications, and it's just finding the staff to take care of the patients. We've been standing up additional clinics to give monoclonal antibody infusions, and that takes nursing staff from the hospital. We have been working very hard to get patients that are well enough to be discharged to a facility, but perhaps not well enough to be discharged to home. We're working with the state to get those patients sent out of the hospital. But right now they're causing a bit of a backlog in some of our hospitals. We could make more room in our hospitals if we were able to get those discharged a little bit more quickly. But they're generally not holding up an ICU bed. Of course, they're holding up a non-ICU bed. So it's not quite as detrimental to the flow of the ICU patients. We are holding patients from time to time and frequently in our EDs because we don't have an ICU bed for them. We've been taking transfers from hospitals around the state in transfer patterns that we've not usually done. But everyone in the state is really anxious, and beds are a short commodity.
Thank you. So the age 25 to 44 group has the highest number of cases. Why is this number so high? Let me start with Dr. Graves.
That's a really good question. I think there are a number of factors that play into that. So first, we know as a state, our most vaccinated age group is actually the older population. 25 to 44 are less vaccinated. And so it makes more sense to me that there are cases in that group. They are also a really social age range. They're working, they're going out in the public. And so that is, I think, an important thing to consider. Last thing is a lot of those people are parents. And so I'm a parent, I have children in school, and my children could be at risk of getting COVID at school, bringing it home to me. And so I think those three factors put that age group at particular risk in regards to getting COVID-19 and becoming ill from it.
Anybody else want to add to that?
I'll add briefly. I'm not an epidemiologist, and so I can't speak to that to this from that angle. But in a purely anecdotal observation, as I talk to my counterparts and I talk to administrators and people who are in the healthcare business, and just neighbors and friends, many of the people who might be my age or a little younger we're all vaccinated, but we all have children or grandchildren who have chosen not to be vaccinated for one reason or another, whether it's just misunderstanding or a firm belief that it's not correct or not safe, or whether it's just busy lives, like Dr. Graves mentioned. All of those things are factors. But I think that's why in my opinion, that's why we're seeing so many more young people with COVID now, is because they're the subset of our population that's not been vaccinated for whatever reason.
Thank you. Dr. Ross, let me direct this one to you. Who are you seeing being hospitalized the most from the virus? Are they vaccinated or unvaccinated?
I think that we see a same pattern than my colleagues at Intermountain, Steward, or University of Utah. I'd say 90+% of patients that are requiring admission to a hospital, sadly, are unvaccinated patients. Very rarely we do see patients that are coming in with the needs for hospitalization that have been vaccinated, and usually are immunocompromised or complex medical conditions that led them to experience a severe breakthrough disease. But again, overall, it is the unvaccinated that are being admitted.
Does anyone else want to add anything to that question?
Yeah, I'll just chime in a little bit. Completely agree. That's what we're seeing within Intermountain. We watch this ratio really, really closely of people that are admitted with COVID-19. So they have to have some kind of symptom of COVID-19 and test positive. And we look at the ratio of unvaccinated to vaccinated. And in general, in the floor patients, it's about 80% that are admitted are unvaccinated, 20% are vaccinated. And in the ICU, we just put this in the chat, the ICU is about 90% unvaccinated, 10% vaccinated. Those numbers vary. They go up and down a bit depending on the day you look at them and the methodology you use. And we anticipate, we expect that the percentage of vaccinated patients in the hospital will continue to grow. And the reason that is that more and more people get vaccinated, more and more of the population gets vaccinated. That increases the number of vaccinated people in our communities. And, just by sheer numbers, they're going to grow. So, as we follow this and trend this and people see that proportion grow, that's going to grow in proportion to the amount of people getting vaccinated. Okay, so that's just kind of one thing to highlight. And then the other thing that I think really needs highlighting is that when we look at the patient that gets admitted that is not vaccinated, okay, so those are the people that get admitted, they haven't had the vaccine, their average age is about 50. Okay, and when we look at people that get admitted to the hospital and have been fully vaccinated, their average age is 70. Okay, so the vaccinated admissions are much, much different than the unvaccinated admissions. The vaccinated people that are failing the vaccine and are getting admitted are older and generally have 2 times the amount of medical medical comorbidities than those that are unvaccinated. These are the people that fail vaccines. These are just the people that we know fail flu vaccines, pneumococcal vaccines. They're older people. They have a harder time to generate an immune response to the vaccine. And this is what we expect. Okay, so the two populations, the unvaccinated and vaccinated, are very, very different. The folks that are vaccinated and fail the vaccine are older and medically more complex than those that are unvaccinated. So it's a subtle point, but it's a point worth really mentioning, that those that are unvaccinated are 50 years old on average, and many of them don't have any medical comorbidities.
Kelly, do you mind if I add something?
Please do. Yes.
I think we are all seeing the percentage unvaccinated in our acute medical floors and our ICUs. The thing I want to highlight, though, is that the vast majority of our deaths are unvaccinated. So at the university, it's 90+%. So even if you are admitted to the hospital, you are less likely to die from COVID-19 if you are vaccinated. That's an 11-fold risk. So unvaccinated people are 11 times more likely to die from COVID-19 than someone that has been vaccinated.
Very good point. Thank you. Thank you. Thank you. So with FDA's full approval of the Pfizer vaccine, and hopefully we'll see full approval of the Moderna, et cetera, do you see this having an impact of hospital capacity, and people feeling more comfortable, taking the vaccine because it's fully approved and by the FDA? Who Dr. Roos or whoever else?
Kelly, thanks. I certainly wish for nothing else than for more people to jump on board and realize that full FDA approval of this vaccine was really the last step and removal of the last barrier and justification for not getting the shot. We know that if we as a population, as Utahns, we're in a high percentage vaccinated, our hospitals would not be in a situation that we're in right now. The ICUs would not be at 90+% occupancy. So I think it is time to have another crucial conversation with the unvaccinated and say, the science, overwhelming science, supports the safety and efficacy. And there's hundreds of millions of these doses administered now over the last 8+ months. The world has more experience with this vaccine than probably any other vaccine in that same time period. This vaccine has been studied more thoroughly than probably any other medication in the world. And it has gotten full approval, not just in the United States, but across the world. So it is time to get the vaccine.
Anybody else want to add anything to that important statement?
I'd love to add something, because it's an and, it's not a rebuttal by any means. The global estimate of number of doses of COVID-19 vaccine administered across the globe is 6.3 billion, B with a B. So 6.3 billion doses of this vaccine has been given across the globe. To Dr. Ross's point, this is the most studied vaccine in our history, period, and, hard stop. And so, I think it's just a different time, right? If we would have gone back 8 months ago and somebody said, hey, I'm really nervous about this. I'm not sure about the safety profile. We only have these, couple studies with 40,000 people in them. I really need to get more data. Now's the time to say we have lots more data. This has been extensively studied in the US and abroad. We have very significant studies on efficacy and effectiveness that shows that these are really, really good vaccines. And we know the safety profile. After 6.3 billion doses of the vaccine, we have studied that safety profile well, and we know it, and we know what to expect. And so, it's a different time in our world and how we interpret and look at these vaccines now. Early on, we didn't have a whole lot of data, but now we've got so much data that shows that these are effective vaccines. They prevent death, hospitalizations, routine infections, and they're safe. And so I think it's, to Dr. Ross's point, you're absolutely right. It is time to have a different conversation about these with the amount of data that we now have, which is much, much different than we were in 8 months ago.
Thank you.
If I may add to that too, certainly I can, I will agree and give a here to the comments that have been made. Very well studied, very safe medication. It seems that people, there are probably still a number of reasons why the people who aren't vaccinated are not vaccinated, and some are just, it's a matter of logistics. I'm sure there are people who just haven't gotten around to it. But there are some who are really have the wrong understanding, and it appears as that people are listening to their own news sources, their own sources of information, and there are people who, we must understand, there are people who truly believe they're doing the right thing because of the information they've been given through various channels. So how do we change their minds, or how do we convince them? And it needs to become personal to them. And we've talked about this. This was something we talked about before we had the vaccine, and we were trying to get people to wear masks. It has to become personal, and it becomes personal in a variety of ways. They get sick with it themselves, or somebody in their family gets sick, or something clicks on the news. They see overwhelmed hospitals in New York. I know that the sight of seeing refrigerator trucks with bodies inside of them was very shocking, and it made it become personal to many people. And it's those kinds of things that happen that makes it click for some people. But and I think when the FDA fully approved the vaccine, it clicked with a few more people, and we have seen we saw a little uptick in the number of people getting vaccinated, but it's not to the extent that we really need to really save the number of lives that we really can save. And so there are other things that probably have to happen that make it personal. And I know I'm stepping into political waters here, but at some point it becomes personal when it's required of you to be vaccinated. And many of us feel that there needs to be a bit more of that kind of process going on right now, because people aren't just choosing to do the right thing like we all hope they will. They're not choosing to do the wrong thing. They're just not choosing. They're just staying out of the discussion, and we need to help it become personal. And if someone's required to be vaccinated in order to do something that they want to do, that's a step that makes it become personal. And I realize it's a very political sensitive issue, but it's a perspective.
I hope you guys will be okay, because this is one of the questions. I'm going to jump around a little bit, but to that point, I'd like to ask you guys your thoughts about President Biden's mandate in mandating vaccines, and your thoughts about that, if you feel comfortable answering that question.
I'll be brave and start out, and then the others can add in. But
gotta have some fun here, we gotta.
I'll say that I was a bit relieved when I heard that there was going to be a mandate and that CMS was going to require hospitals, for instance, to require vaccinations in order to participate with Medicare insurance. And I was a bit relieved because it is very political. And if there's some outside source requiring us to mandate a vaccine, in a sense, we're not causing it. It's a bigger, higher source that's causing it. That's a very candid view, but I was very relieved to think that we were going to get some relief in our hospitals by President Biden's mandates. Now, I know those are yet to be rolled out and yet to be clearly defined and clearly approved and vetted. We'll have to wait and see.
Kelly, can I add to that?
Yes, please.
HCA healthcare and, being a part of HCA as a MountainStar healthcare, we're very carefully following the evolution of this mandate provided by the president. And we want to make sure that we are doing everything that we ought to do to be compliant and follow the order. It is sad that it has become a political topic. And I think that ideally you want to convince people that the why behind vaccination is stronger than anything else, and you don't need a mandate. And though at some point mandate is necessary to get the minority on board with whatever it is, it also creates a more polarized situation, and the conversation becomes even more heated. And as a healthcare providers in a situation where our staffing is extremely tight, ultimately we can't afford a single nurse to walk out. We can't afford a single respiratory therapist, single lab technician, single physician. So we live on an edge where we all believe that vaccinations are absolutely essential. We all believe that mandate, though hard, it is something that is needed at this point, 8 months into it. But at the same time, we are very worried that implementing mandates will cause loss of staffing. And as it stands right now, we're barely able to care for patients that are coming through our door. How are we going to do that when we don't have staff? So I think that maybe the appeal to you, Kelly, and your people is everybody else is help us to message the need and the essential aspect of vaccination, so we don't have to have a conversation about being mandated or not mandated, but having a conversation about that we have vaccinated everyone who can be vaccinated, who is eligible for vaccines.
Kelly, I'll just add a couple of things. And so I just did 2 weeks of clinical service in September. I saw a lot of COVID-19 patients and I had a lot of conversations about vaccines. So the first I will say is I have very, very rarely admitted somebody with a vaccine side effect. I have commonly admitted somebody with a COVID-19 severe illness. And so I think it's important to balance those two things, right? So the risk of not being vaccinated right now is extremely high, and I think that belongs in the conversation. The second thing I will say is that a number of my patients have said to me that the reason I did not get vaccinated is because it is so political. And so I think anything that we do that adds to the political dynamic here is risky as well, right? So we wear seatbelts to protect each other. We do a lot of things to protect each other. I think many of us feel that the COVID-19 vaccine is similar. So the university is the only healthcare institution that has required that of its healthcare employees. The reason we made that decision is because we need our workforce to be safe and intact, as Dr. Roos points out. We need our patients to feel like they can come to us and not have a big risk of getting COVID-19 in our hospitals. And so I think what I would urge the public to do is, yes, please get a vaccine to help us continue to take good care of you. And also, please do not continue to make this polarized or political, because we are hurting each other by doing that. And there are people who feel like they can't get the vaccine at risk of angering those that they love. And no one should ever be in that position. And so I think we need to back away from the political nature of this conversation.
Good point.
Yeah, and I'll just share a story I heard over the weekend. I have a friend of mine who has a 90-year-old mother who's on hospice, and that individual got infected by their hospice nurse and infected the entire family. And now, and that hospice nurse, and actually, I don't know what hospice company this is, and I didn't ask, I didn't want to know. But so that healthcare worker was unvaccinated, came in and infected a 90-year-old who is, on hospice, and their entire family. And, the amount of trauma that has led to that individual's family about who infected mom, and who is causing her to have more symptoms in this time of just absolute distress, has been devastating. And that was because there was an unvaccinated healthcare worker that spread this virus to a patient. And I saw a comment in here that was saying that, if a vaccine doesn't stop someone from getting and spreading the virus, how does this reduce the spread of the virus? That comment's just not true. Vaccines stop the spread of the virus because they prevent people from getting infected. Is the vaccine 100%? No, it's not bulletproof by no means, but it greatly reduces the chance of getting infected. And then once infected, getting sick, and once sick, getting in the hospital, and once in the hospital, going to the ICU and death. So I'm not a CMO. I can't speak for Intermountain Healthcare at all. Vaccines are our tool. And, when we started this pandemic, we were hoping for a vaccine that was at least 50% effective. That was our hope. And we were given through science just this incredible vaccine that in some instances over 90% effective in reducing infection and severe disease and hospitalization. That is our tool. Masks work, absolutely. Social distance works, absolutely. We need to do those, especially right now during this surge that we're in. But if we're looking at a long-term solution, it's vaccines, period. And if people are not going to get vaccinated, they will get infected. Like Delta is just that transmissible. That's your choice. Is you're eventually going to get infected and run the risk of an infection, or you can get vaccinated. And so I'll leave the politics for the politicians. I'll take care of the healthcare, and just say that this is our tool, along with social distancing and along with masking. But vaccines are our tool out of this, and we just need to do whatever we can do to get more people vaccinated to prevent these long-term complications.
Kelly, can I just add one last little thing?
Yeah,
Just a
please.
comment. Awesome statements from everyone. I've said this before, but in my opinion, the choice to not get vaccinated is the choice to get COVID.
Yeah.
Plain and simple.
So just to clarify, with each group right now today, are you mandating all your healthcare workers to be vaccinated at this point or not?
Who would you like to start? Does it matter?
Why don't you start, Dr. Graves?
So I think everyone heard me say the University of Utah does require vaccination of its clinical workforce. We do allow an exemption, and there is a process for that. But yes, we are requiring the COVID-19 vaccine at the U.
And how about Intermountain?
We have not mandated it yet. We are waiting to see the final details of the Biden administration. Clearly, if a vaccine mandate is tied to CMS reimbursement, we have a duty to care for our population that is under Medicare and Medicaid. And if that's the case, we'll absolutely move to a mandate. We have to care for that population. If that's what it means, caring for that population, that is our duty to the community. So, but as of right now, we have not mandated.
Thank you. MountainStar?
We are in the midst of making sure that we're going to be compliant with the president's order and how to implement that. In the meantime, we're mandating a universal masking within the walls of our hospitals. as the closest thing that we can right now come up with protection of our employees and our patients.
Great. And Steward Health?
Steward is not mandating currently. We have made a big emphasis on educating and re-educating and taking down barriers. We do have universal masking throughout our hospitals, have that for a long time, as does everyone. And we're looking and waiting to see on this, the CMS, how CMS comes down on this. We will absolutely require it if it becomes a requirement for participation with Medicare.
Thank you. So just talking, let's turn to the Delta variant, and just wanted to ask, what plans are you guys implementing now that the Delta variant, now that the Delta variant has spiked, and is what's happening with your plans there? Are you limiting visitors? How do we get on top of the Delta variant, and what are your hospitals doing in that space?
Well, Kelly, I'll try to address that, and maybe in the meantime, I'll address one of the questions in the chat too. Currently, probably 100% of COVID-19 infections are the Delta variant. That is the reason why we see the rates and the infection as high as we've ever seen it, because the Delta variant is so much more transmittable and infectious than the previous version. So I think the question in the chat was, why do we see such high numbers now with the vaccine available now for 8-9 months? It is because of the aggressive version of the new mutants, the Delta variant. Now, what are we doing? Now, we're universal masking. And there was a question in the chat about universal masking, why masks are being enforced in the world of vaccines being so effective. Again, if everybody was vaccinated, there will be much less need for universal masking, number one. And number two is, though, as Eddie said, this is phenomenal vaccine with 90+% efficacy. It's not 100%. So there's going to be 5 to 10 people out of 100 that will not mount appropriate immune response to be immune to the virus, and therefore they can get infected, breakthrough infections, and they could spread it should they be unprotected, or should they not be wearing a mask and wearing a mask. So I think the two reasons why masks are important is what I just mentioned, is lack of vaccinations and a potential breakthrough. Now, in terms of visitations, visitations are limited, sadly, and I can tell you, I personally feel that is one of the hardest things that we are putting the families and our patients through. But we're doing it because we want to make sure that we provide a safe environment for everyone, from the staff to patients and their family. And we limit them, to a small number, and we limit them in the ICU, and we limit them for COVID-19 patients. But we do make an exceptions, particularly for the COVID-19 patients that are at the end of their life, because I think at that time, the visitation rights needs to be, we need to be very flexible. We need to address the ability to have family members with dying loved ones.
Thank you. Anybody else on the Delta variant? And
Delta variant aside, we're clearly making contingency plans of how to continue to, accommodate the number of patients that we're seeing. And some of these contingency plans are really hard to make, and they're really hard decisions. And so, just an example, I oversee 9 different medical specialties across Intermountain Healthcare. And 2 weeks ago, I had to go to them and say, we're at a point where we may need your help in the hospital. We may need your help in urgent care. Not what are you comfortable doing, but what can you do? And so I'm now literally going and asking dermatologists, rheumatologists, endocrinologists to come and help out in urgent care, come help out in a hospital, and do what they can to help provide care for patients. We haven't had to go there yet, but we're close. And this gets to the point of Dr. Roos and Dr. Jarrett and everybody talking about staffing. our biggest limitation right now is staff. Nurses, MAs, and physicians are just getting exhausted and tired, and we need to spell them. And contingency plans like this leads to different care. It doesn't lead to the same care that everybody's used to getting at Intermountain, University, Steward, HCA. It's different. And I really hope that we aren't having to activate some of these plans. I want my rheumatologist to taking care of rheumatology patients. I want my endocrinologist managing diabetes in the clinic. And I want our professionals that manage hospital patients to do that. But that's where we're at in terms of trying to make plans to accommodate this surge. Unfortunately, our case counts have plateaued. We've seen our hospitalizations stabilize, not increase. And in order for us not to have to activate these plans, we're going to have those numbers go down, especially as we head into the winter season and holiday season. And so, when you ask what are we doing about the Delta surge, that's just the bare bones basics of it. Is we're trying to accommodate the best we can with the staffing that we have.
Yeah, and then what's the likely, what's the next variant that comes out, and are we gonna, how we, staying on top of it? It's not just the Delta variant, right? We're gonna have to expect that other variants are gonna come out real soon.
Yeah, and I'll just comment on that. Just being
Yes.
all the vaccinology and vaccine research is, all the variants that we've seen. So, we started with the ancestral strain and the Alpha variant that we kind of came through in the summer, and now the Delta variant. All the variants that we've seen, our vaccines protect against them. So we've been fortunate in the fact that spike protein that our vaccines are directed towards is a very strong, immune reactant protein. And so all the vaccines are protective against the variants we've seen. The issue is that if there is rapid and significant COVID replication anywhere in the world, that is going to be a source for variant generation. And so this is why it's so important to not only get the United States vaccinated, but also to get the rest of the world vaccinated. And I can tell you, people are looking at the US as being a source of variant generation that is going to affect them, right? So because our vaccine uptake has been slow and hasn't been universal, the United States, if we continue to have COVID-19 transmission at rates like this, we will be the ones generating variants. And the worst thing that could happen is a generation of a variant that can escape the immune process generated by the vaccine.
Kelly, I'll add a couple more thoughts. Oh, go ahead, Dr. Graves.
No, so I think I want to use this as a way to address a couple of common myths. So in order to manage the Delta variant, I think what we need to do as a community is reduce the amount of COVID-19 transmission, because it's twice as transmissible. And right now, our hospitalization rate is exactly what it was when our case rate was twice as high in the winter. And so the likelihood of someone getting sick and being hospitalized that's unvaccinated is really high whenever there's a significant amount of COVID-19 in our community, which is why we talk about masks and why we talk about vaccines. Two big myths I think are important to talk about, and my colleagues that maybe are more experienced in these areas can talk about them, but one is natural immunity. And so natural immunity is not a reason to not be vaccinated. We don't know how long it lasts. We don't know how good it is, and it's variable from person to person. So natural immunity is not as protective as we would hope. The second is herd immunity. So there's been lots of conversation about herd immunity over the last 20 months, right? And we hope that we get there and end the pandemic. The thing is for us to have enough COVID-19 infections to get to that point increases our hospital capacity, increases deaths, increases suffering. So herd immunity is not a good answer to end the pandemic and to get through the Delta wave. And so really it's vaccination, 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 preventing transmission until all of us can get a vaccine or have a good immune response to that if possible. Sorry, Dr. Jarrett, go ahead.
Oh, that's good points, Dr. Graves. I apologize. My thoughts to add to what's been said, and I know that we're all doing the similar things and doing the same, taking many of the same approaches. Your question, what are we doing to make capacity in our hospitals, I believe, to handle the Delta surge? I'll just start out by saying in Steward hospitals in the last 10 days, we've had as high of hospitalization numbers of patients in the hospital with COVID as we did at any time during the winter surge. So we're still high, and we have plateaued, but we haven't started to go down yet. We're hopeful that we'll start to go down, but we're as high as we've ever been with COVID patients in the hospital. We're doing all of the contingency planning, bringing back retired nurses, trying to get them out of retirement, looking for skilled nurses everywhere we can look around the country and elsewhere. But that well has really been tapped by just about everyone else, and so that's a struggle. So we're all doing things like the medications like remdesivir, an antiviral that we give to patients when they first are at a certain point in the hospital, or certain guidelines that we do. It helps a little. We're all doing monoclonal antibodies, and I know that there's been a big push on monoclonal antibodies. I want to, as Dr. Graves mentioned, maybe clear up a little bit of confusion about monoclonal antibodies. Monoclonal antibodies are a good tool, but they're a very narrowly limited tool. And in the old farm vernacular that I was taught by my dad, giving people monoclonal antibodies is a little bit like trying to close the barn door after the horse is out. It's a challenge. It's a lot of effort. There's a lot of work. And if we were to give monoclonal antibodies, this is something that most people don't understand. If we were to give monoclonal antibodies to every single person that the FDA says is eligible for it, we would have to give that infusion to between 100 and 200 people to keep only one of them out of the hospital. So it's a Herculean effort to try to give that much monoclonal antibody. And it takes, by the way, it takes nurses and facilities and resources to give those monoclonal antibodies. It's a multi-hour process to get it. And so while it's a good tool, and we are all doing it, and it is, and we do keep people out of the hospital by selecting patients appropriately, it's only a small tool. And I hate to hear people say, well, if I get the disease, I can always get one of those infusions that will keep me out of the hospital. It's not that simple. And I hate to see us rely on that as the tool when we are stepping past the vaccine that everyone has so eloquently discussed.
Kelly, maybe can I add something to that?
Please do, yes.
Think about it that prevention is far more effective than therapy. Prevention is currently available with an FDA fully approved medication. Monoclonal antibodies are under the emergency use authorizations only. So they do not have an FDA approval. So they are far more, quote unquote, experimental than your current vaccine. Number one. Number two is, as Arlen said, it is far more complicated, involved, and time-consuming and expensive to administer monoclonal antibodies than a single vaccine shot. And it is more invasive, and it is higher risk intervention by far than a prevention. So I think that's something very, very important to realize and remember, is that always therapy is far worse, far harder, far more dangerous than prevention.
Yeah.
Now, at the same time, I would love to address a question from your audience, from Manuel, who asked a good question about vaccines, mandates, and your healthcare force. And is it a bad idea to keep unvaccinated nurses or staff on your premises? And so I think that's a complex question. Number one, first of all, is as long as you have a universal masking, you limit the spread of disease within the walls of your hospital. You protect your staff, you protect your patients, number one. Number two is a mandate vaccine or vaccination in general will keep your workforce healthy, alive, and therefore they will come to work and they will be able to care for your patients there in the ICU. So I think a huge motivation and reason to have your workforce, and it doesn't matter if it's your bakery or your automotive shop or hospital, is to have vaccinated because they are healthy and they're functional, and then you can run your business. In our case, running business meaning caring for people that are in the need of healthcare. So I think that's, hopefully that answers the question.
Yes, thank you. So I think one of the last areas I just wanted to touch on are booster shots. Again, I think there was some confusion, rolling the idea of booster shots, timing, and who was going to get them. Just want to turn it over to you on, the impact of booster shots and how you see booster shots, rolling out in Utah. It seems like it's starting to, but the effectiveness and helping it get on top of some of the virus and then just the rollout. Why don't I start out with Dr. Stenehjem?
Yeah, I can just kind of summarize the current evidence that we have on boosters. So boosters are available right now for the Pfizer vaccine if you're 6 months out from your second dose, if you're 65 years of age or greater, if you're between 50 and 64 years of age and you have a chronic medical condition, you should get a booster. If you're 18 to 49 with chronic medical conditions, you can get a booster, you can consider it. And then if you're in an occupation that puts you at high risk, particularly, healthcare workers, teachers, and the like, boosters are available to you. So the why behind the boosters, if you look at the effectiveness of the vaccine over time for the Pfizer vaccine, is what you see is that you start to have waning effectiveness when you get to about the 6-month range. And that waning effectiveness is really predominant in those that are older, 60 years of age or older. We also see that in those with chronic medical conditions that you also have some waning as well. And so we've gone from about a 90 to 95% effectiveness down to about an 80 to high 70s, depends on the study you look at. And so a booster shot will then stimulate your immune system again, your antibody levels will go up, and you'll have that higher protection again going forward. Keep in mind, there's a lot of vaccines that have a shot at 6 months. So hepatitis B, for example, you get a shot at 1, 2, and 6 months. That's likely just, that's just the schedule of vaccines for that particular organism. And I suspect that within COVID-19, the general kind of administration of the vaccine will be a 3-shot series. And so a booster shot is absolutely needed for those people. The data coming out of Israel looking at the effect of the booster on reducing subsequent infection is actually quite good. And so when we look at the Israeli data and see what is the effect of that booster at 6 months, it actually reduces the risk of infection in those that have been boosted very significantly compared to those that haven't been boosted. And so the early data looks great from the effectiveness standpoint. Moderna has not shown very significant waning of immunity in terms of vaccine effectiveness. We're watching this really closely, but Moderna still is right around that 90% mark. Most people think the reason that is because Moderna has about 3 times the amount of RNA in the vaccine as compared to Pfizer. Okay, so far Moderna looks solid and doesn't need a booster. FDA is going to be evaluating this coming up though. J&J is something to watch. We know that the effectiveness of J&J is not as good as Pfizer. The studies on a second dose of J&J look really good in terms of boosting immunity, and FDA is meeting this month to determine a second shot for those that have received J&J. So I anticipate that there'll be recommendations forthcoming for J&J by the end of October. Okay, so if I kind of look into the crystal ball, Pfizer booster, absolutely. J&J, I suspect will have booster shots approved by early November. Moderna, we're just gonna have to wait and see. But absolutely, if you fall into those categories for a booster, I'd say by all means, go get it. I'll pass it on to the others about operations.
What about the mix? You hear a lot of discussion about mixing the boosters. So like I got J&J, what if I, the idea about getting a Pfizer booster,
right.
So
mix and match studies are certainly far behind the standard studies of boosting with the same vaccine that you got originally. So if you got Moderna, if you got Pfizer, there's no reason to consider a mix and match strategy. I would stick with the brand that you got. J&J, there's a few studies on it, not a ton, but when you look at places like Canada and Germany that use an adenoviral vector vaccine platform like J&J, happens to be a different one called the Chadox vaccine. They do mix and match as well. So I think it's probably safe, but the best data is looking at a second shot of J&J. And that's likely what's going to be improved, because there just isn't enough data to really say whether or not a mix and match strategy with the J&J and the subsequent RNA platform is going to be effective.
Great, thank you. So we have 2 more minutes left. And it's been great that you guys have been looking at the chat and feel like you wanted to call out and answer some of those. So I want to just give you each, if you've been looking at the chat, or if you want to make one last point of a myth or whatever, I just want to do one more rotation with our last 2 minutes. So I'd like to start with Dr. Jarrett.
Well, thanks for the opportunity. Just briefly, there was a comment or a question in there about whether or not hospitals are motivated to get more COVID diagnoses by financial reimbursement. I don't think any of us on this call are financially connected. We're not CFOs. We all deal with the medical. So I don't think any of us could talk specifically about reimbursement plans and programs. But I can tell you from sitting in senior strategy meetings and leadership meetings, no one is saying, let's get more COVID patients in the hospital because we're making a killing on it. No one is saying that. And when I look at what happens to our hospital system, not just in Utah, but at our hospitals outside of Utah, the pandemic has been a hit financially to our systems. It has not been a boon by any stretch of the imagination. We have no motivation to overdiagnose. We can't overdiagnose because all of us know the consequences for Medicare if we inappropriately diagnose. And we have systems that help us diagnose correctly and appropriately. We're not motivated by finances here, none.
Thank you. Dr. Graves.
I am not an infectious disease specialist or immunologist, but I see there are concerns about the long-term effects of the vaccine. So I'm going to start with that. And then Dr. Stenhjem, you can add anything if you think I'm totally off base. So the first thing I will say is mRNA vaccines have been studied for many, many years for other illnesses. And so these are things that were being studied in the mid 2000s, like 2005, 2006, for other use. To my knowledge, we've not seen long-term effects as a result of those studies. The other thing is that mRNA enters the cell to help make spike protein that the immune system then recognizes and prevents serious illness from COVID-19. That mRNA is degraded extremely quickly and so is not around to cause long-term side effects. And so I feel very confident saying that I think we're not going to see long-term effects of this vaccine that are anything but protective and beneficial. The last thing I'll comment is my understanding of vaccine development is that this is often how it looks, is that we do studies, look at immediate effects, approve under EUA, and then it unfolds kind of like it has. And so I don't anticipate long-term effects of the vaccine. And then the second thing is vaccine contraindications. The only thing I have ever seen is immediately post-transplant, but I'll let Dr. Stenhjem weigh in on those two.
All right, Dr. Stenhjem, we're
Yeah,
changing that for you.
I'll take it real high level and quick. And again, I'm not a CFO, but when I've been in meetings on this, the amount we get reimbursed for a COVID patient, most of the time does not cover the costs that we have for that COVID patient. So this idea that we're making money off of COVID patients is absolutely not true. Okay, we're actually losing money because it takes so much to care for these patients. So that's one. Two, it's a great point of long-term effects of vaccines. When you look back in vaccine history and you look at what are complications of the vaccine, all of those complications are identified within the first 3 months. Okay, if you look at intussusception with rotavirus vaccine, if you look at Guillain-Barré with the flu vaccine, when we look at side effect profiles and complications of vaccines, they all occur within the first 3 to 4 months. I can't think of an example. Besides immunity, I cannot think of an example of a long-term effect of a vaccine. And the fact that we've had 6 billion doses of this vaccine administered in the past 8 months we know the side effect profile very, very well. And I'd say we probably know it better than any other vaccine in the world. And so at this point, we know the profile of this vaccine. I don't anticipate, the vaccinologists don't anticipate identifying long-term effects of the vaccine because that's really hasn't been identified. And the mRNA platform has been studied for decades. Okay, so these, I can feel confident to say that these are safe. My last parting thing is just to this group, to Filip, Kencee, and Arlen, thank you. It's so much fun to get to know you over the past 8 months. And I think this has really brought our health systems together. And it's been such a valuable experience for me personally. So, it's just an honor to be on this platform with you all. And lastly, I would just say to people, what are you doing to help with this pandemic? This is going to be, a once in a lifetime experience. I know when I look in the mirror at the end of the day and when the end of this pandemic is over, I'm going to be proud of what I've done for this community. I'm going to be proud of what Intermountain has done and the healthcare community's been done. And I would just say, think about what are you doing to help to get through this pandemic and get reliable information, get the resources that are actually true, get it from reliable sources. And, how can you help the community? And we're asking for your help, whether that's making sure your employees are vaccinated, whether you do testing, whatever it is. I think we all just need to know, what are we all going to do to help us get through this pandemic and get on the other side of it. So I'll pass it on to Dr. Ross.
Dr. Ross, you can finish us out. Summarize at the end of this.
First of all, Kelly, thank you for giving us the platform. Thank you to all attendees for spending the time with us and asking the tough questions in the chat. So thank you for that. Second, this is a real disease. Let's remember that this is a disease, not a political issue. Therefore, let's go home and talk to your loved ones, your friends, your coworkers, your employees, and say to them, this is a disease. Let's forget about politics. Talk to your doctor if you need any information about what to do next. Thank you.
Thank you, all of you. Again, thank you for what you're doing. And every time I hear what we're all doing in Utah, we all should feel very fortunate to have you guys. And thank you again, and all of your employees for what you're doing and helping us better understand these issues. The chamber will have, this has been recording, this is being recorded and will be on the chamber's webinar YouTube website. So let's share it and just keep good information and education, and hopefully we'll all get on top of this and we'll do it working together and keeping the facts straight. So thank you everybody once again.
Thank you. This has been wonderful.